Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today, we welcome back on the show Maryna Mammoliti. She's a psychiatrist. Her Kevin MD article is titled Discover the Power of Occupational Therapy, a Solution for Doctors and Patients. Maryna, welcome back to the show.
Thank you. I'm excited to be back a year later. Always looking forward to your articles and your show. So I'm glad to be back again.
All right. Now, for those who didn't get a chance to listen to our first episode together, just briefly share your story and journey to where you are today.
Okay. So I'm a psychiatrist in Canada. I practice in Ontario. I see a lot of physicians in my practice. I do community psychiatry. I also do emergency psychiatry downtown Toronto at a hospital called CAMH. I also focus a lot on ADHD in general population, but also in physicians and physician health. So that's my practice, my psychiatric practice. And I also am a certified executive coach, and I work on boundaries and I work on career changes. So that's my other thing. And I am a mom of 4 children and 3 cats at this point. We've collected them during COVID, and a dog. And so that's a bit about myself. And what else? I was heavily involved in the medical politics during COVID. I was representing psychiatrists with Ontario Medical Association. I was the chair of the section, and I'm still involved in promoting physician interests through my involvement in our provincial association at that level.
Specific to psychiatrists in Ontario, what are some of the biggest issues that's facing that specialty, and why is it so important for physicians to advocate?
Well, I mean, I think the issues facing psychiatrists, I think, is very relevant facing every specialty. One is burnout, right?
Mm-hmm.
Just yesterday, I was connecting with my psychiatrist colleague, and we were just chatting about the acuity of our cases. My own, patient load has been very acute. People are in a lot of crises, a lot of need. I think every psychiatrist is facing a lot more acuity in our cases, just like I think any physician right now, whether it's a family doctor, whether it's specialist, I think everybody is facing a ton of acuity in the patients we're seeing. So aside from the burnout from COVID that we will experience because, we've been in so much chaos and uncertainty every day, I think the patients we're seeing need so much more from us when we already have so little to give because COVID took so much. And so I think for psychiatrists, number one is the burnout from the acuity of the patients, aside from, again, navigating the fractured system because other people have burnt out in the system, whether it's like case managers, whether it's, other therapists, or getting help for our patients outside of ourselves has been really hard because a lot of people left positions, a lot of people have gone on leave. And obviously compensations, because in Canada we are paid by the government, so compensation has been always a big issue for psychiatrists because we're one of the 3 lowest paid specialties in Canada usually. So that's always been a big part about how do we get compensated. Many psychiatrists worked after hours during COVID because the need is so great. How do we compensate? How do we keep people in psychiatry? Because it starts with medical students. Medical students may not find psychiatry attractive because of the intensity and low payments to go with it. So it's always hard to get students to be interested in psychiatry.
Now, when you talk about things like physician burnout, what's the response you normally get from politicians and those who make those medical decisions affecting physicians when you advocate?
I think it's very different between what the response we get versus what actually happens. I think on, when there's interviews and whatnot, the response is always, oh, yes, we care. But unfortunately, to actually implement systemic changes or actual changes that actually would support, wellness for physicians is very different, right? And I think in particular, I don't know what it is like in the US, but at least in Ontario, the amount of complaints against physicians have gone up. If you've noticed, all sorts of like disciplinary complaints have gone up despite physicians trying to do their best. That in itself is adding to, the burnout too. And I think burn for everybody because, you have extra paperwork when you're trying to do your best. So I think even sometimes, kind of the punitive ways of dealing with physicians has been another issue out of COVID when physicians are doing their best and they might not be able to meet certain deadlines or things like that because it's just not possible. The insurance companies have been like really difficult with all the paperwork. For example, I know it affected family doctors. I know psychiatrists too. There's insurance companies that want updates every 30 days for somebody being off. I don't have appointments to bring somebody back every 30 days just for insurance paperwork. I have patients to see. And then you get these angry emails and paperwork and all sorts of demanding emails from the insurance companies and threatening that they're going to cut off the patient if you don't see them in that short a period of time. That's been a big issue, to be honest. That's been a big issue of dealing with the insurance companies for people who are off, because they have to come see their family doctor, psychiatrist. Like, somebody has to sign their paper, and the frequency of the paperwork signing has like skyrocketed during COVID for us. So again, is one place you're talking about physician health, physician wellness, yet systemic changes to support that are very difficult. People taking a leave is very difficult. Finding coverage for a leave is very difficult. So it's been very difficult. It's been absolutely difficult in terms of the platitudes versus action. The platitudes from politicians or action to actually accommodate wellness.
All right, let's talk about your Kevin MD article now. It's titled,
Totally.
Discover the Power of Occupational Therapy, a Solution for Doctors and Patients. Now, how did this article come together?
Well, talk about, physician wellness and insurance companies, right? How did this article come together? Well, first of all, I'm going to tell you up front, my really good friend is an occupational therapist. And how I became a friend with him is basically because we shared a patient. We shared a patient, was returned to work, dealing with these forms. And, she started seeing him to help her return to work, and we connected, sharing the information and the return to work process. And then, I saw his work, he saw my work. We really liked, I really trusted his work after seeing it. And so I connected with him, had a couple of meetings. Then I shared patients with him more and more. And I really started relying on his recommendations to help me with the return to work process for my patients during COVID, particularly because the amount of paperwork, that is thrown at me as a psychiatrist is absolutely unmeasurable. Like, I cannot tell you. And so I started relying on him, on the professional opinion, and our patients were getting better. Our patients were going back to work. And so that really became a friendship. And, he's a very close friend of mine. We worked a lot on supporting people with ADHD, because ADHD is very poorly understood in the workplace, especially physicians. So he sees a lot of my physician patients to help with return to work, because many workplaces where physicians work do not understand accommodations. Like, they just don't understand that a physician could still work with accommodations, and especially for ADHD. And, one of the most common reasons I see physicians and I start assessing them, it turns out to be ADHD, is charting issues. They get behind with paperwork, charting issues, which is, again, so common and overwhelming. And I've had people get in trouble, for charting. They'd get disciplinary action when it was been unrecognized ADHD. And their environment was never supportive of their ability to do charting in the first place. It was a conflict between environment, ADHD unrecognized, all the pressure and stuff, yet they were punished, right, with no supports. So we forged a good working relationship, and, we worked a lot on people with ADHD and return to work. And also because I really rely on occupational therapists in managing my patients, in return to work, in assessments, when people ask about what is their impairment, what is their whatnot, I really ask for that. And especially workplace assessments, because I can't be with the patient at work. I can figure out how one's depression might impact, something, but, I can't be there with a police officer on the job and assess how their trauma is going to get triggered when they're out in the station or out on the road. And, these are the things that we're being asked about, when we return people to work, is this functioning, and, sometimes safety about guns, sometimes this. And it's like, how can I tell you that when most physicians have not had training on occupational implications of any condition, let alone mental health? I've done a lot more work of this, so I have more skills to assess this, but most, like an average family doctor or psychiatrist, does not have these skills, yet we're asked to do that, right? And same for physical function. Like, most physicians are not going to be watching how many steps a patient can take before they get short of breath. Like, we don't have the time, we don't have the place. Like, we're not going to go outside with a patient and walk them down the street and watch them to say, oh yeah, they can walk 50, feet or whatever. Yet a lot of these forms ask us to these specific questions that I can't really answer. And so we don't have the education. We might not have the ability to actually assess this objectively. I can't go to somebody's workplace and assess how they do in the workplace because it's outside of our scope. That's not
Mhm.
what physicians are taught to do, yet insurance companies expect us to do this and then blame us if we can't answer it to their liking, and then tell the patient, they got a form rejected because your doctor didn't do it right, when in reality, we did it to the
Yeah.
best acknowledgement we have. And so occupational therapists help a lot with that. So, that's how this article came about, is because I've looked at, I have a big thing with boundaries. Like, what are the boundaries? And I realized how much I rely on occupational therapist to help me maintain my professional boundaries, because I can't answer questions I'm not trained in assessing.
Sure.
And this is what this paperwork often asks us to do.
What are some of the typical behavioral health conditions that you could refer to occupational therapists? Because I think that there's a perception that occupational therapists mostly deal with physical issues, but a lot of the behavioral health issues they can also handle as well. So, what are some common behavioral health scenarios that you would send patients to occupational therapy for?
Absolutely. Yeah. And that's an absolutely misconception, because occupational therapists are able to do physical and mental. So
Hmm.
pretty much any condition, whether it's depression, PTSD, ADHD, trauma, schizophrenia, they have the skill set. And as I mentioned in my article, when I trained in my psychiatry residency, we had occupational therapists on inpatient, outpatient in so many areas. And the occupational therapists were working with such a variety of people. And like when I worked in a hospital setting, we would rely on occupational therapists to assess safety to be discharged at home. Like, can people call 911? Can people, manage a simple phone call? You would assess that in various populations. You would work with an occupational therapist to assess that. The physician didn't do it in inpatient or outpatient. So I'm not sure why we're expected to do that in the community when we don't have the skills.
Hmm.
So occupational therapists have the capacity to address any of the DSM-5 conditions based on their training experience, because there's occupational therapists who work with children versus the ones who might work with geriatric population or adult population. So they might have their own focus, but they usually are exposed to the full range of this.
So, I want to
So
talk about a scenario that you brought up about a
Mhm,
physician with a potentially undiagnosed ADHD having
mhm.
problems completing charts. So, why is it difficult for those with ADHD to complete charts?
Perfect example. Why? First of all, let's look from the environment. If a physician has no desk, no space, is in the middle of a nursing station where you're constantly interrupted, there's constant noise, there's noise from the computers, buzzing, people talking, right there, the environment in itself could be so counterproductive for somebody without ADHD, let alone with ADHD, when that distractibility is huge and staying on task is hard because of ADHD, right? And think about, where do most of us chart? In a busy nursing station or open space station. While we're charting, we're often interrupted by a medical student, by a nurse, by a phone call, by a page. There's constant interruptions. So somebody without ADHD is very difficult, let alone if there's ADHD, right? The other thing is, we often don't actually have working computers, or we have to find a computer. So
Hmm.
even if we are trying to chart, we might not actually have access to a computer to chart, right? So noise, lack of accessibility. The other thing is, our patients come in with multiple issues. We have to document multiple different issues, no matter what your specialty is, right? And so people with ADHD might get distracted in trying to kind of synthesize and spend much longer time trying to write a note
Hmm.
than they would. Or because they got distracted in the assessment, they might forget what the patient said, and they'll try to kind of trace back or like remember what they said. The other thing is, for doctors with ADHD, is that they can get tangential. So let's say they'll be documenting on one issue, and they'll like over include everything that was said about that, and then they'll get distracted and go off on a tangent, and then they take much longer to actually document the appointment. So because they often kind of get tangential. So there's that too, but there's often distractions. There's often that. There's often also just the sheer exhaustion from having to pay attention when you're not medicated and EEG is not recognized. So they might feel much more exhausted at the end
Hmm.
of the day when people catch up on charts. And procrastination is a big issue in ADHD. So people will procrastinate until there's some sort of a crisis. So for somebody like that, an occupational therapist could start with assessing, like, what is your actual physical environment? Because again, as physicians, we're not even taught to consider, how's my environment supporting me or perpetuating an issue, right? And if the environment, if you're charting in the middle of the, emerge, or constantly getting interrupted, or people are constantly at your office, or you have to constantly answer emails, how can we expect you to finish your charting during the day or within the encounter when you're nonstop interruptions? So some accommodations could be making sure that you have like 4 walls around you, or that you put a sign, unavailable charting. So some kind of external barriers or boundaries, or noise canceling headphones. Right. And it sounds so simple, but it's actually hard because most of us don't do that. Right. And sometimes it could be certain software that might help us, with like dictation or charting, whatnot. The other thing that most of us have to do these days is EMR, right? EMR is so complicated. And again, if you really think about it, when I trained, we still had paper charts, right? So if I signed, I checked off, I handed off. If I made a mistake, usually a nurse would come and talk to me and said, oh, you forgot this box, or, I would add addendum, whatever. The nurse would be usually kind of my check-in system. If you think about now the EMR, depending on which EMR you have, first of all, you have to click. If you don't click the right box, you might not be able to proceed further. Right. Yeah. So you have to remember the sequence of boxes to order for each order that you might be entering. That in itself is hard. Then, you might have to be flipping between different windows to get the information. That in itself, again, is a cognitive task and might be really hard for somebody with ADHD or in charting to stay focused on several windows and retaining that information. And because with people with ADHD, they might struggle with working memory, which is kind of like your notepad in the moment, right? So if you're kind of flopping your notepad to try between windows, it might be hard for you to retain the information. So it might take much longer to get that note done. And you might be getting distracted and going very far back, looking at the charts, synthesizing. So it takes like so much longer than an average, person. And so again, you see, those are cognitive function. Those are how long does it take? How long does it take to do this command, that command? Occupational therapist would look at how many clicks do you take to do this? How many clicks does this take? What are the things? Because they look at the functional assessment versus we don't stop and think, well, it takes me like 20 clicks to get to this. It takes me 10 different order sets to actually manage one condition. And just that simple understanding of what it takes cognitively and functionally for us to accomplish a task or a charting note might make a big difference, because you might come up with a template, or you might come up with some other strategies to help the physician manage all of those clicks, or even realize that this is why you're struggling, instead of like, you're bad, you're unprofessional, you're stupid, because this is the message we get, right? Is that you're unprofessional. So, again, that in itself is an issue for charting in ADHD. And where occupational therapists, where I use sometimes occupational therapists to help the physician understand what is your cognitive demand of your task, what gets in the way of that cognitive demand, what is the environment around you that either helps you or gets in the way.
Now, in a primary care setting, what kind of red flags or what kind of clues should you look out for in order to refer someone to occupational therapy for a behavioral health condition?
So clinically, when would I suggest to refer is, let's say you're working with somebody for return to work process or assessing workplace impairment, workplace accommodations, because even in US, right, there's laws about protecting and workplace accommodations for people with disabilities, and mental health conditions, DSM-5 conditions, are considered a disability by, most laws. So let's say somebody is in a process of returning to work, and you have to do paperwork about what are their accommodations, what are their limitations. Probably a good idea to get an assessment by occupational therapist. And whether it's you request the employer, whether the insurance company involved, right? Because there's often insurance company involved, because they will give you a more objective assessment of, okay, this patient can sit for 20 minutes, or this patient can do this for this long. Now you have that. You could recommend to the employer what accommodations they need, even physical, right? So it's not just cognitive, it could be also physical, because they do both. So return to work process. When you're trying to assess level disability, let's say how disabled one might be, sometimes that gets involved in car accidents or other issues. So occupational therapy assessment would go a long way because it would actually follow the patient to their house. They see the in-home assessment, work assessment. The other time is if people are struggling at work or school, because again, an occupational therapist could say, okay, what's the struggle? What is a functional assessment, whatnot? So you sometimes have kids who are struggling with school. You have, university students who are struggling. They might need that, because occupational therapists, again, can teach you organizational skills and other supports for school as well. The other times is, let's say somebody wants to come in, because occupational therapists do a lot of kind of occupational coaching, because they do like values inventory, skills and stuff. So if somebody comes in and says, like, I really don't know what I want to do with my life, I don't really know where, so kind of like that career coaching, they can also help with that. So it's a vast range. And in certain places, occupational therapists actually do therapy, so they could do cognitive behavioral therapy, they could do other therapy, so depending what the local regulations are. So sometimes I will refer my patients for therapy, especially when I want my patients to get skills, because occupational therapists are very goal oriented, because sometimes you'll hear somebody say, oh, I went to therapy, I don't know what I did, I have no idea. Well, skills. Sure. So if somebody, is depressed and you want them to have behavioral activation, or you want them skills. I recently referred a patient who doesn't want to leave the house because they developed agoraphobia during COVID. So I referred them to occupational therapy to help this patient to slowly be exposed to the outside. I can't go to the patient's house. I'm not going to sit with the patient in the car. Occupational therapist will come up with a plan to do some gradual exposure so that they actually can go outside.
And my final question, tell us on your take-home messages that you want to leave with the Kevin MD audience.
My big take-home message about this is, one, remember, we need to keep our boundaries to sustain our wellness, right? Occupational therapists, aside from great, amazing colleagues, can actually help you with that boundaries by keeping you within your professional boundaries of your knowledge and what you actually know when we're talking about disability and impairments and assessing our patients. Two, they could absolutely help us move from a deficit to a wellness model, because they come up with all sorts of accommodations that we might not be aware of, that our patients can use, that could be supported by legal, expectations of workplace accommodations, school success, things like that. Three, they're really useful for us. If we're struggling at work, if we're struggling, even sitting, like the way we're sitting, our stations are set up. Is that good for your back? Is that good for you, cognitively? How many patients can you actually work with before you burn out versus how many you're, stuck dealing with and you're burning out and you're not going to be available for anybody? So for yourself, like, how does that help yourself in terms of your own setup, your practice setup, your physical office setup, your EMR setup, your sitting arrangement? And, the other thing about this, about like occupational therapy and whatnot, is that, look, they have a huge range of skill set. And if you build some relationships with ones in your area, you will know which one's available for you, because our biggest thing is we don't know. We're not out there meeting people who are not physicians. And that collaboration goes a long way, because you'll get to know. And I tell people all the time, like, occupational therapists are evidence-based regulated professionals. So, there's lots of coaches out there. And like, as I told you, right, I'm certified coach too. Unfortunately, a lot of the interventions that some coaches use are not evidence-based. And so I have an issue with that a lot with ADHD, because there's lots of ADHD coaches. There's no regulation. So you could tell somebody, go run in the mud, and it helps you. There's no accountability to that when there's no evidence to that. Occupational therapists are regulated health professionals. They have a license. They can only recommend things that are evidence-based, they're held to a standard. And so their strategies are, evidence-based, objective strategies. If you ever have a lawsuit or a board complaint or anything like that, and you relied on occupational therapy assessment, you relied on evidence-based assessment to make your decision. You didn't rely on some random advice on Google. So I think we also forget that. And the service to our patients, when you go to somebody who's a regulated professional, there is a little bit of that safety and regulation and responsibility. So that is my other thing about that.
Maryna, thank you so much for sharing your time and insight. Thanks again for coming back on the show.
Thank you.